Hi, Mr. Lawton.
Hello.
Dr. Ritchie. I'm one of the ward doctors.
Oh, hello, Doctor.
I understand you want to talk about what's going on.
Yes, I'd like to. I'd like to know a little bit. I seem to have spending too much time in hospital at the moment. It's my second visit in under a fortnight.
No, quite right.
Yeah.
Could I just confirm that I'm speaking to the right person just before I get into things?
Graham Lawton it is. Yes,
Graham Lawton.
yes.
And your date of birth?
I'm 27. Yes.
Okay. And you happy for me to address you as Graham or?
Yeah, that's okay. Yeah, sure.
So, Graham, if you could just quickly for me, just recap what's happened. You said it's the second hospital visit in less than a fortnight. If you could just talk me through things just so I make sure.
Well, I've had
I've
a collapsed lung, and I had this. I was in, as I say, just under a fortnight ago, and there was all sorts of various technical terms used, but basically, as I understand it, my lung has collapsed. They use some sort of funny term, pneumothorax, if I've pronounced it correctly.
Quite right.
But basically, as I understand, it's a collapsed lung, and they've drained off the air to, I'm not quite sure how that worked, but they were draining air off, as I understand, and that enabled it to apparently reinflate. And then, I went home again as usual, and about just a couple of days, being at home, it all seemed to start up again, and I'd got this pain on the right side, and I was breathless and sort of feverish and shaky, and I mean in many respects I felt worse than I did before the first time I came in, and apparently, so I'm back here again, as I say, about just over a week since I was last here, and apparently it seems to be the same thing as I understand.
Okay.
At least this is what I'm thinking. It seems to be the same. I mean, is it the pneumothorax thing, whatever it's called, come back again?
Not quite, no.
Oh.
And I think you've alluded to the fact that you do feel perhaps more unwell this time than a week's previous.
I would say so, yes, I would definitely say so.
Yeah.
Yes. So, I mean, obviously the first visit didn't really do the trick.
Okay. I mean, lots of the signs and the symptoms that you're describing, these fevers and the shakiness, these are commonly signs of infection. Is that something that you'd thought about?
You mean as well as the lung problem?
Well, any form of infection.
Oh, no, not really. No, I mean, I've just gone through, had the tests done and everything, and, waiting to see what it's all about or whether it is the same thing.
Okay.
It is very frustrating if it is the same, repetition of the collapsed lung thing, but, because it obviously wasn't sorted out the first time properly.
Okay. Well, what you have is a problem with your lung, but as you've sort of suggested, this is a different problem. This is an infection as opposed to a collapsed lung.
So something I caught in hospital the first time?
Most likely, yes.
Most likely, right, the MRSA?
I don't know what bacteria is causing this, and that's certainly one question that we need to ask.
Yeah.
Before I describe this infection, I'd like to just step back one sort of week and ask if you remember when they put the drain in. Do you remember them discussing any possible side effects or mentioning that lung infection could be one of them?
Not that I recall. I mean, it was pretty unpleasant really, and I was sort of worried about what was happening, So I honestly don't know whether somebody told me. It probably went in one ear and out the other, I should think, if they did. So basically, no, I would say.
It's hard to take
things
in
I can't recall.
when you're feeling not right. So, I mean, if there is anything that you want me to recap or repeat because you're not sure you've quite got, please do just stop me.
No, okay.
When a chest drain is put in to treat a collapsed lung, obviously we're breaking the skin.
Yes.
And the skin is our best barrier to infection.
Right, okay.
As a result, every time we break the skin, whether it's to take blood or to put a chest drain in, there is a risk of infection developing.
Right.
And I think the most likely explanation is that you have developed a lung infection as a consequence of having this chest drain in.
Oh, right, I see. Okay. I mean, is it a bad infection, or is it? I mean, as I say, I certainly don't feel good with it. But
No.
I mean,
And the most important thing is obviously you, and clearly you felt ill enough to come to hospital, and you're telling me right now that you're not feeling very well. So I think by that measure alone, this is an infection that needs prompt treatment. You're not feeling right, and we need to make you better. In the first instance, we found this by doing the chest x-ray.
yeah.
So you've had that picture taken again.
Yes.
And from that, it's very clear that you've not got a collapsed lung, but there is evidence of this infection.
Right. So the pneumothorax thing isn't here again.
The pneumothorax is not there anymore.
Right. Okay.
No. However,
infection.
there's a different problem which needs to be addressed.
Okay. What's that?
So this is a chest infection,
Right.
and there are different forms of chest infections.
Yeah.
Some of them will be fairly localised, and these get a special name. It's called an empyema. So it's just a way of describing a localised infection.
Just localised. So
It's in the
localised
lung.
chest infection.
Yeah, it's
Right.
not spread throughout the lungs, it's one very focused area.
Yeah.
Now, these can be quite serious infections. They can make people feel very, very unwell.
Right.
So we need to do two things, really. We
Yeah.
need to think about gathering as much information as we can to make sure that we're treating this in the best possible way.
Yeah.
And secondly, we need to start treating you.
Sure. Yeah. Oh yes. Yes. Sooner the better. Yeah.
So I think the first step is to gather information. Okay?
Yeah.
And when I say first step, these are not going to happen days apart. We're going to get as much information as quickly as we can and start the treatment as quickly as we can.
Yeah. Yeah.
But I'll discuss them separately.
These are more tests when you say information.
Yeah,
Yeah.
absolutely.
Okay.
So you've had a series of blood tests done, including samples from your blood, just to make sure we can't find any evidence of infection that's spreading there. What I think we need to do is to take a sample directly of the infection.
Yes.
Now, when you had the chest drain put in, they'll have used a needle to put some anaesthetic in to numb the skin,
Yeah.
and then they'll have put some slightly larger needles in to let them put the drain in.
Right.
What we need to do is about the first half of that. So what we'd like to do is numb the skin, and
Yeah.
using a needle, take a sample from this area where there's infection. That's going to do two things. Firstly, it's going to let us find out exactly what bacteria is causing the infection, so we can make sure you get the right
I see.
antibiotic treatment.
Yeah.
Secondly, I've said that some of these infections can be very serious and make people very, very ill.
Yeah.
And in some cases, if we look at them, we think this is a pretty nasty one. What we might actually want to do, with your permission, of course, is to help you get better more quickly by removing that focus of infection, by removing the bacteria. And to do that, we would suggest putting another drain in to actually let the pus drain out if there is any.
I see. Yes. Okay. Okay.
Now-
How long is this all going to take?
Well, I think the initial tests we'll do after we finish talking, if that's okay
Sure.
with
Sure.
you.
Yeah.
And we'll get some results from that very quickly.
Right.
We'll be able to let you know almost within the half hour, really,
Oh.
if we need
Good.
to do another drain.
Yeah.
We'll start you on what we think are the best antibiotics, but to grow and find out exactly what organism is causing it might take 24 to 48 hours. So we'll get some information pretty much immediately and some in a day or two.
I see. I see.
So I think that's our plan of attack right now.
But if you're sort of doing is there a risk of the same thing happening again? Because it was, you admit it was caused by the original draining of the lung, the infection, and it's sort of going to stick things into me again. Isn't that, there's always a danger, I suppose, of causing a further infection?
We've got to be absolutely honest and say everything we do carries a chance of a negative effect, of a side effect. However, what we do all the time is balance risks and benefits.
Yeah, oh yes. I mean, yeah, that's fair enough.
Yeah.
No, I mean, what you say seems to make sense, and obviously I don't want to continue as I am because
You're not right.
it could get not right, and could well get worse, couldn't it? I suppose. Yeah. So, no, I'm quite happy to, if you think that's what we should do, then okay, we'll do it.
I think if we do require another chest drain to be put in, I think you alluded to before, it was hard to take it all in when you're ill.
Yes, yes.
And we do talk very quickly often, so whether you want to spend more time discussing it, whether you want to have a family member present to go through the consent process, just to make sure you understand. And certainly we can speak to the chest ward and we can get some information sheets to give you a chance to read while we're waiting for that first result.
Yes, okay, well I'll do that. I'll read some stuff up just in case, but I mean what you said makes sense, there's a way forward, so yes, I'm basically I think at the moment quite happy to go with it, but I'll have a look at the written material.
Okay, so let me just quickly reflect on what we've said. So what we talked about in the first instance was the diagnosis and the fact that there is this infection,
yes,
it seems, on your lung, the need to investigate it further. Firstly, by taking a sample.
To find out what it is.
To find out exactly what it is.
Yeah.
And that's going to help us guide treatment.
Yeah.
And then the treatment options, which are antibiotics, which we'll need to give you. And we may need to put another drain in.
Yeah. But with the antibiotics, once you've identified, and if you do need the other drain, the combination of those will actually clear all this problem up.
I would hope so, absolutely.
Yes.
Yeah.
Yes.
There's
is there a possibility it might not? You said you would hope so.
No treatment is guaranteed, and what we're offering in the first instance is what we think is the most appropriate treatment.
Okay.
When you put a drain in, there are different types and different sizes. And sometimes to drain an empyema, so this infection, if you can imagine, if you're trying to let air out, you might need a very small tube, because it will flow freely.
No.
But if this is infection and pus, sometimes we would need a bigger drain.
Yeah.
So depending on what the x-ray looks like and what the fluid looks like, we may need to speak to some colleagues who put these larger drains in. So it may be a slightly larger drain than previously.
Yeah.
Or it may be one drain that we think will work and then we need to just increase the size.
That won't affect me in any particular way, the bigger drain.
We have to acknowledge that, and I'm sure you're highly aware that having a drain in, it's not the most comfortable thing.
This is what I was thinking about. It was pretty horrible the first time, so you're really saying this could be worse.
We may need a larger drain, so it may be a bit more uncomfortable.
Right. Well, if it has to be, doesn't it? So that's okay.
But I think you are aware of the possible sort of discomfort, and I think what we should do is make sure that if it's pain that was a problem with it before, we've got plenty of regular and as needed painkillers prescribed. And if there are any other problems that you've experienced with it, then we'll look at those and we'll discuss those and try and find out a way to prevent or limit them.
Right, okay. No, that sounds reasonable. Okay.
Is there anything else that we can talk about?
No. As I say, if it does the job, then, sooner the better, really.
Okay.
Yeah.
Well, we'll crack on now. We'll get these tests arranged, and as soon as we've got the first results back, we'll come back and talk it through with you some more.
Okay. All right. Thank you, Doctor.
Thank you very much.
Thank you.
Okay. Thank you very much, Dr. Ritchie. When you read through the scenario, what were the sort of the issues that you picked up on? What do you think were the potential problems and pitfalls?
I think reading through this scenario, there were a few options. The most likely expectation I had was this would be a man who was feeling upset or angry about the fact that he'd had a treatment complication. Now, this didn't prove to be the case, so I was quite relieved by that. Then the next possible idea was that this was information giving. So if this is not a man who's upset about the fact that he's had a treatment complication, it will be a man who wants to know in detail perhaps either why it's happened or what the treatment options for it are.
Okay. I mean, it felt to me like you'd predicted he wouldn't be happy for a further chest drain to be inserted and sort of played the scenario from that angle, sort of treating him very much with kid gloves. Would that be a fair?
To an extent, I think that's fair. I think when someone's had a sort of a problem, then I think you've got to address them in as soft a manner as you can. And the other thing to consider is that there's not as yet an absolute proven indication for placing a chest drain. He's got a plain film that's suggestive of an empyema. He's not had a tap, and he's not had any more detailed imaging.
Okay. So ultimately, the patient completely agreed with your plan. So, what were the key things that you did do you think, to get him to concur with our plan?
I think firstly, I made it clear to him that there was a structured train of thought. We wanted to look back to his previous experience, understand that, and acknowledge early on that this was potentially iatrogenic. So by acknowledging that and accepting that, it removes the chance for him to become upset about that later on. Latterly, what we did was provide a structured plan for investigation and management, and we discussed a range of options and how his treatment would evolve over time. So I think he was given a fairly clear picture, and that allowed him to understand things.
Okay. So had his tone been a little more militant? Was this a hospital acquired infection?
Is this a hospital acquired infection? I think most likely. Not proven, but I think it should be treated as such.
And so, if he were, a more of an angry individual, or this had made him more angry, how would you have proceeded?
I think a lot of the scenario would have been handled in the same manner. I think you've got to ultimately explain what's needed in terms of investigation and management. If he was more upset, I would have firstly allowed him to express how his feelings were and why he felt like that. I would have given him a range of options for how to progress his complaint, should he want to make one, whilst at the same time explaining that my main motivation at that point was to ensure he got best quality care this time.
Good. I thought you did very well there. I think your introduction was very nice. I think you need to be careful with the communication station, that you're not taking, this isn't the history taking station, so be wary of taking a detailed history. But in this scenario, you do need a small amount of the history to allow you to move on with the rest of your explanation, to understand a little bit of background about where the patients come from and where there are potential problems. I think you were right to predict that he wouldn't want a further chest drain, having been traumatised by the first one, but the rapport that you developed with him meant that he was pretty much willing to do whatever you wanted. So that was good. There was opportunities to offer further discussion. You offered him written information. That's all very good. And ultimately, the sort of the, if we were being more goal orientated about this scenario, then the patient agreed to your plan. So job done. Well done.
Thank you.
So the focus of this scenario was one of persuasion. You have a patient with a prior poor experience, and you're asking basically for them to undergo the same procedure again. So it's important to understand their point of view at the start, and to then impress upon them the importance of them undergoing the same procedure. There's also probably a medical error here, or at least a cause for complaint, and it's quite genuine. If the patient had been more upset or angry about that, then our role here is to support them in making a complaint, to refer them to PALS or offer to investigate it yourself, but to not allow that to divert your attention from the main goal here, which is to get them to agree to a further chest drain. And really your tactics here are really to deflect the anger and the wish for a complaint, by offering other venues for that to be addressed.